today's presentation, I'm just going to go through a bit of detail about what CanRisk is, what data you need to input onto it, how to build a pedigree or family tree onto the system, how to calculate the variant or mutation carrier probabilities and breast and ovarian risks, where to save the files, and obviously that's going to be different for all your different departments, but I'll talk through how we do it locally, and I'm sure you can find a model that works for you locally. Potential pitfalls in using CanRisk, and then we can work through some examples as well. So what is CanRisk? So it's a web-based tool. You can just request a login for it with an NHS web address, email account, sorry. And it uses the new version of BODICEA, the breast and ovarian analysis of disease incidence and carrier estimation algorithm, in order to try and establish people's risk of developing breast cancer given certain scenarios. And then there's been bolts onto it to add the ovarian arm. So yeah, over the years, including detecting sort of variant frequencies and things like that, so that your likelihood of picking up a genetic variant in certain situations. You can just Google CanRisk, it will take you to the website. It's only a model. I always say to people, it looks very accurate, it gives you risks to decimal places, but it is a model. Please use it with caution. If you get a printout and think that really doesn't look right, check through your inputs, check it, you know, it makes sense what you put into it, and you can always email the CanRisk team as well if you get a calculation that you don't think seems right, and they can give you an explanation as to why. We use a bit of a standard insert in our letters now when we're quoting information from CanRisk that just talks about some of the limitations of using it. So it talks about the fact that it's only as good as the input data that you put into it. How when research improves over time, we learn more about these risks, the figures that the software producers will change, and how it isn't an exact science. So it's just like with anything, it's a tool, it's useful, it produces useful figures that can help with your counselling, but it's not perfect. There's different softwares available that can do this. One of the big other ones is Tyrer-Cuzick, that's used by several centres. There's some differences between CanRisk and Tyrer-Cuzick. So CanRisk looks at beyond first and second degree relatives. It puts in additional factors like alcohol use, or contraceptive use, age of menopause. It allows you also to take account of more genes. I think Tyrer-Cuzick just allows you to input information about BRCA1 and BRCA2. And it's also CE marked now. So the tool's been optimised for use in sort of specialist genetic services, and it's very user-friendly now. I know some of you have used it and some of you haven't, but I'll show you it and we'll go through each of the steps in order to work through some examples. We use a family history questionnaire that also when we send out family history questionnaires, we also send out a bit of a CanRisk summary as well, to allow you to pick up some of the risk factor data that you need to put into CanRisk when making an assessment. And if anyone would like a copy of that, I'm really happy to email it out to you. Just drop me an email and I'll send you a copy of ours. CanRisk uses different risk factor information when working out its calculations. This is just a summary from their website of what it takes into account. So we know some genes are sort of just primarily associated with ovarian cancer, like BRIP1, so that's obviously only in the BRIP1 calculation, whereas some are more predominantly breast cancer genes and aren't used in the ovarian cancer calculation. It also takes into some other factors like age of menopause, which is only thought to be more of an issue with breast cancer, age at first birth, live birth, etc. Some other procedures or health concerns can be more associated with ovarian cancer, such as tubal ligation procedure, sterilisation, or endometriosis. So the software uses different risk factors when it's trying to work out risks for breast and ovarian cancer. So I'm just going to hopefully flick over to it just to so you can see it on here. So you come to here when you initially log in, you log in up here and you can request an account as well. If you haven't got one already, I've already logged in, you can do start a CanRisk calculation and it takes you to this screen here. It then works you through multiple different tabs, including personal data, lifestyle, women's health, children, breast screening, medical history, polygenic risk scores, and family history. Polygenic risk scores is more of a research element, and we wouldn't be expecting people to upload data there currently. But you can just go through, and there's obviously some mandatory fields and there's some that don't have to be filled in, but the more information you put in, the more reliable assessment that you're going to get. So you can toggle between female and male. It talks about your ethnic group here, what country you live in. Pop in your date of birth of your patient, height, current weight, and you can swap between imperial and metric. So you're not having to convert it yourself. It calculates the BMI for you. Talks through lifestyle factors. You no longer have to calculate the units yourself. It's got a way of doing that for you. So you can just put in sort of daily, weekly, monthly glasses of wine, etc. So I can run through an example with you. So if I have somebody that's born on the 1st of April 2001, and they're 180 centimetres and they weigh 70 kilograms, it's calculating that for you. A lifestyle, Casey drinks, and maybe she has weekly a couple of glasses of wine. That's a relatively small glass of wine, so just be mindful of that. And maybe she has a couple of bottles of beer a week, and that will work out your units of alcohol very easily. It talks about when they had their first period, so maybe she had it at 13, asks if you ever taken the oral contraceptive pill, and then talks through how many years in total that they've taken it for. So this one, maybe 1 to 4 years. Have you taken the pill in the last 2 years? Yes. Have your periods stopped now completely? So no. If you click yes, then it would give you when they had stopped. And it says, have you ever used hormone replacement therapy? And again, if you have, it drops down a menu so you can select how many years you've been taking it. Have you been taking it in the last 5 years? And the types of types of HRT, and it's also got information. So if you're unsure which type, it will allow you to do that, or it allows you to select from the brand name as well, and that will tell you what type of HRT it is. Okay, so my lady's young, she's not taken HRT. Allows you to enter how many children you've got. So this lady might have had 1 child and they were born in 2023, and it allows you to select male or female child. Breast screening. So my lady probably had a mammogram, she's in her 20s, but if you select yes, then it talks about breast density. So most people, the answer to that is no, but if they have had a mammogram that does give the breast density on that, it is a really strong prognostic factor, and it is worth putting in if you have that information. We don't have that information for patients in Nottingham. Medical history. Have you ever been diagnosed with endometriosis, as that's a risk factor for ovarian cancer? Have you ever had your tubes tied, a tubal ligation procedure? So sterilisation. So yes, no, unknown. And then you can select if you've had surgery, so if you've had a nephrectomy or you've had a mastectomy. And then have you ever had any of these cancers? And you can select down between breast cancer in the second breast, ovarian cancer or pancreatic cancer. And if you select any of those, then it asks you to input the age. As say polygenic risk scores, most of us won't have any of those files to upload. And then it gets down to the section of building up a family tree. Okay, I'm just gonna skip back to my other presentation because I just want to talk about how do you find breast cancer and ovarian cancer in CanRisk. So breast cancer in CanRisk is taken to mean an invasive breast cancer. It doesn't mean a ductal carcinoma in situ. However, most places around the UK, genetics department wise, just add 10 years to the age of the diagnosis of the DCIS when they're inputting it into the CanRisk files. And it needs to be high grade DCIS. I find that difficult because if it's your patient you're seeing with breast cancer and she's had a high grade DCIS, then inputting her 10 years older. I think it works well for relatives on the pedigree. I don't think it works so well if you've got your index case, the person that you're seeing that's had a DCIS. But that's what we're doing around the country. An ovarian cancer means an invasive epithelial ovarian cancer. Non-epithelial tumours, like a germ cell tumour of the ovaries, shouldn't be inputted, or a borderline tumour. There's some debate about that. They're not typically associated with BRCA1 and BRCA2. There's some thought they should probably be excluded, but definitely the germline tumours should be excluded. In regards to ovarian cancer, we also think of cancer of the fallopian tube in that remit, and also primary malignancies of the peritoneum. So, and also stick tumours, which are a precursor to ovarian cancer. So sticks, peritoneal, fallopian tube, and ovarian cancer should be inputted, but not womb or cervical cancer. So when we're building the family tree, which is the last section that I've just got to, there's multiple different ways of doing it. If it's in bold, it circles so that it indicates that the information is complete. And you can set up the family tree multiple different ways. So option one, you can just do a first degree family, which would look like this, or a second degree family like this, and it will just set you up a template and you can go and delete people or add people to that. You can also just put in the number of brothers, sisters, sons, daughters, uncles, aunts, etc., and say add grandparents, and it will give you the basic template yourself. Then there's little widgets which you can get when you hover over the circles, and that allows you to, a symbol like this, a chain allows you to add a partner, a arrow up allows you to add a parent, this allows you to add a sibling, add a child as a down arrow, and add consanguineous partners. So if they're like in a relationship with a cousin or something like that, that would be deemed to be a consanguineous partner, so somebody who they share a blood lineage with. Males are always put in as a square, females are always put in as a circle, and a diamond is you're not sure. Dizygotic fraternal twins, a little arrow up, and filled in triangle is a monozygotic or identical twin. And you can add half siblings as well. I just bring us back to the CanRisk tool. I don't know if you want to go down and just try this yourself as well if you've got it open. But I was going to use option 2 for my lady. I was going to say that she's got a brother and a sister. We already know that she's got a daughter because we've inputted that information further up. And I was going to say she's got an uncle and an aunt on her mum's side and just an aunt on her dad's side. And I've said to add grandparents. If you click through, that should give you a pedigree that looks like this, a family history that looks like this. So this is her daughter. If you click on her daughter, then it brings up her daughter's information here. So if you want to give her a name, you can give her a name to make the pedigree a bit easier to work through. Click on the patient yourself and add in information about them. So here we've got the ability to add in the diagnoses at this point. You can add in the pathology of the tumour. So if she's got a breast tumour, you can say whether it's estrogen, progesterone, HER2 positive or negative, cytokeratin 14 and cytokeratin 5/6. I don't tend to fill those bits in, but I do fill in the receptor status of these 3. The gene test, so if she's had a genetic test, you can fill that in. There's differences between a mutation search and a direct gene test. Let me just go back again to my presentation to show you that. So a mutation search is a diagnostic test. So it's a whole screen of a gene, okay? Whereas a direct gene test is a predictive test. So that's what we do in clinical genetics, where we just test somebody for a specific variant. Whereas a mutation search is where we read the whole gene. So those are your sort of mainstreaming diagnostic tests. The direct gene tests tend to be the ones that we do in genetics. Okay. And then you can select whether the mutation is present, whether it's absent, or you're unsure. So my lady's not got cancer, so I won't put anything like that in there, but she's got a brother, so I can say that her brother was born in 1997. Okay, and he's fine. If I wanted to add his children, I would add a partner, and that would give him a child. If I want to change the sex of the child that he's got, then you just click on him, and then you can go across to here and put that it's a female, and maybe she was born in 2022, and it automatically calculates the age for you. And again, you can put in her name. So there we go. That's her name there. And the brother as well. And then you can put in perhaps that she's got a sister who's maybe a little bit older than her, so born in 1999. Again, calculate the sister's age. We'll call her Chloe. And we can put in that she's had breast cancer at the age of 25, okay? The pathology, we could say that it's a triple negative, so just go through and select those. And the gene test, so she's had a mutation search because they've looked through all of it, and then that will select those genes for the whole panel. There's some genes that we don't test for currently, so BARD1 we don't test for currently, so we can take that one out. That is going to be added shortly. And then it automatically sets to mutation absent, but we could say that her sister's got a BRCA1, so we said mutation present in the sister. Okay, it will now, which is very helpful, it didn't in the past, then say what tests that she's had on the pedigree so that you can see that. So then I'm going to put in her father, say that her father is born in 1970. So I've got a big 55. I might say that he's got prostate cancer and he's been diagnosed with prostate cancer at 54. He's got a sister. I can just put in that she was born in 1965 or 66. We'll call her Joan, and we can put in that she's developed breast cancer at 45. If we want her to be, if she's passed away, we can click on the deceased button there, and then you type in the age at which she died. So if she died last year, would make her 58. And then we can obviously put grandparents on here as well. So 1945. Well, and 19. 19. Okay. If you don't know the date of birth, in order for CanRisk to include somebody in the calculations, they do need to have a date of birth. So especially if you've got somebody with like a breast cancer in the family and you don't know the date of birth, you're best estimating it rather than just not putting in anything at all. So I mean, like if it's her sister, but you don't know his sister, you don't know exactly when born, but they thought that she was a few years older than her dad. Just estimate it at 1966. Just add a few years, take a few years off the dad's age. It doesn't have to be precise, but you do want to have her breast cancer being included in the calculation. For the sake, you can just remove people by just pressing the X arrow. So I've decided she's just got one sister. I'm going to put mum's age in as being born in 1960. And her sister being born in 1965. Have those as cancer free. And grandparents on that side have died. Okay. So you've got the ability to swap the ancestry as well. So if your patient's Jewish, you can got Jewish ancestry, you can click on there. You also have the ability to save the files. So you can just save the inputs here, and it will save you just the input data, which you then can reload. That's really helpful if you've got another family member as well, because you can reload the pedigree and then change the pro-brand. So here we have pedigree numbers, so family numbers in the family history clinic setting. You may not have that, you're going to have something else. I always try not to upload anything that's patient identifiable as such. So I try not to upload an NHS number, but you might download it to your system just with a patient, maybe like today's date, you might put in being the 3rd of the 7th, 25. It then saves your file here. You can open the file. And it just looks like this. So a load of data, and you can just do file, save, and save it onto a local drive. So in Nottingham, we save all of our files to the same place. And I suggest that you have a CanRisk file that people within your department can all access. And probably for you in that setting, saving these files under an NHS number would be a sensible thing to do, or NHS number and patient name, so that you've got 2 identifiables in it. Okay. There's some advanced options in here as well, so you can change the chances of finding a variant in different genes. I suggest you don't touch that in the family history clinic setting, but it is possible to do that. To get to the actual calculation, you press calculate down here. As I say, you can load previous files. So if you've downloaded your inputs before and you want to upload them, you can go to this section and load them in from your drive. Just go through and select it. And obviously, if you want to start a new calculation, you can go to the reset button here too. So here, if I do calculate for my patient, it will take me through to a number of different tabs. Here we've got her breast cancer risk. We've got her NICE category for breast screening for breast cancer. We've got her ovarian cancer risk. We've got the pathogenic variants, chances of finding a variant in genes, the inputs and the advisories. I always go to the inputs as one of the first things I do and just check that I've uploaded the data correctly. It's really easy just to do something wrong. Go through and have a look at the pedigree at the bottom and just check it marries up with what you've got in your file. Okay. So if I'm happy, have a look through that. If I'm happy with all that, then I go back to the calculations. So this is predicting her risk of developing breast cancer in the next 5 years, 10 years, and up to the age of 80. So over 5 years, 3.1%, next 10 years, 10%, and between now and the age of 80, it's 55.7%. It gives you a graph here as well, showing her risk, with the dotted line being the general population risk, and this line here being her own estimated risk of developing breast cancer. And then it compares that to what's in the general population as well, and it gives these sort of nice infographics as well, which will help explain risk to patients perhaps that mathematically literate. It can also show your risk at certain ages. So it shows her risk between the ages of 25 to 80. So you can see over the next couple of years, her risk is not particularly high. But then the risk starts really increasing as she gets a bit older. This bit is useful if you're trying to work out whether somebody who hasn't been tested, say in this example for the BRCA1 variant in the family, trying to work out at what age she might qualify for screening. Because with the VHR guidance, we know that everybody who tests positive for a BRCA1 variant would automatically get screening from the age of 25 now. But if they decide that they don't want to be tested yet, they would automatically get testing from the age of 30. But it would only be when their 10-year risk is greater than 8%, I think, off the top of my head, that they would start qualifying for MRI scans. We use this table when we're trying to work out that sort of grey zone for whether they enter, what age they enter screening if they don't want to have a test currently. It also gives you the NICE category. It doesn't give you the very high risk category here, which is deemed to be a lifetime risk over 40%. But it does it does separate out into near population, moderate or high risk. Here, obviously, you can see that her lifetime risk is going to be over 40% anyway, and it gives you her lifetime risk here between the ages of 20 and 80 at being 56%. It also gives the risk between 40 and 50, as that is one of the criteria when you're deciding between moderate and high risk. So that can be really useful in those families where they've just got a family history, etc. And you're trying to work out which risk category to put them in and what screening to offer them. In regards to ovarian cancer, a separate tab again gives you a nice graph showing sort of lifetime risk of developing, the risk from a current age up to the age of 80 of developing ovarian cancer, and also gives that in the nice demographics, nice picture representation over the next 5-10 years and up to the age of 80. Here it gives also the chances of finding a variant, obviously because the sister's got it and she's relatively young, the chances of her having a BRCA1 variant are near 50% because of autosomal dominant inheritance. But it also gives the chances of picking something up in other variants as well. And that can be really useful when you're trying to work out whether somebody meets the threshold for being offered a genetic test. In this scenario, it's very simple. She's got a sister with a BRCA1 variant and she's going to be eligible for a predictive genetic test through genetics. But in scenarios where you're trying to work out with her own family history, and perhaps personal cancer history, whether she will qualify for a test according to the genetic testing criteria. As we've seen that inputs, and it also gives you some advisories. So if there's people on the pedigree where you haven't put in an age and date of birth, it will flag it there as well. Okay, you can print and save that report. Again, it asks you to put in details. I would put in something that you then rename once you've downloaded the file, but it will allow you to print off a report, and you can add in which sections of the report you want to save. I don't just save all of them. Okay. So when we're using the CanRisk tool, it's always worth remembering that it's been validated for women with European ancestry who they've got the data for the research for. It should work relatively well for most Western populations. There's some populations that we know have a really high frequency, a lot higher frequency of BRCA1 and BRCA2 mutations, including Iceland, Poland, and the Netherlands. It does allow you to change the mutation frequencies if you've got an Icelandic patient or patients from the Netherlands, but it doesn't allow you to change it for Polish descent. It's not being validated in like Eastern populations, developing countries. So therefore, if you've got somebody of that ethnic background, it is worth just saying that, you know, this tool hasn't been validated for their particular population, and therefore the information that it provides isn't going to be as accurate. This is just an example of where you can select the Ashkenazi, Jewish, Icelandic, or non-European section. How can I avoid underestimating the risk using CanRisk? So ideally put in as much information as you possibly can. That will help you to make sure that the information is as accurate as possible. We've talked about estimating people's ages, but really try to do that and really try to estimate the age at death if you haven't got those exact figures. If somebody's had a prophylactic mastectomy or a nephrectomy, so say her mother had a nephrectomy in her 30s, it seems really harsh, but you need to put the mother down as dead because then it will only add into the estimations the initial risk, and it won't take into account the fact that she's lived for multiple years after that and potentially not developed ovarian cancer due to the fact she hasn't got any ovaries, rather than she hasn't developed ovarian cancer because potentially she was going to unless she had that operation. So yeah, if they've had prophylactic mastectomies or prophylactic oophorectomies, the advice is just to mark them down on the pedigree as dead at the age at which they had those surgeries. Please try and include as many genetic test results as you've got, and please also try and put in if you've got an Ashkenazi Jewish origin. They're all factors that can really help. And as I mentioned when I was going through the example, if there's not an age or put in or a year of birth, then CanRisk excludes that person from the calculation. So that's why it's really important that they're put in like that. This is just an example here of how you can calculate somebody's age. So if you don't know the grandmother's age, but the patient was born in 2007, then you can work out roughly when that person may potentially have had a child. So it maybe take 30 years off the age that a mother was, maybe 25 for the next generation, and maybe 25 for that, assuming that sort of people had their children a bit younger in earlier years. You can load files. So I know some of you use pedigree drawing software as part of your family history clinic, and there's a number of those pedigree drawing softwares that can be uploaded. So here we've got some examples: DefGen, MediFirst, MRS, Phenotypes, Progeny, and TrackGene. They all have saved pedigree files that can just be directly uploaded into CanRisk. So that might save you time if you've got those. There was a national statement about the use of CanRisk, and it talked about what minimum criteria people wanted to put in order to use the figures from a CanRisk assessment. This is one of the first statements that said everyone agreed that CanRisk should be the tool of choice in making these assessments, and people agreed that there should be at least a 3-generation family tree. You should put in the personal history of cancer, the family history of cancer, the genetic test results from family members, information from both affected and unaffected relatives, modifiable risk factors, alcohol and weight, utilize additional risk assessment information where available, and validated risk assessment information. So basically they're saying if you've got the information, try and put it in there, and anything you put in is going to be really helpful in better making the estimates accurate. When you're using the CanRisk estimates, most people seem to round up to the nearest whole number for breast surveillance, and also for genetic testing. So if your chance of finding a variant is 9.5%, they would round up to 10%, allowing you to offer testing. That's worth bearing that in mind as well. Okay. With CanRisk, they take the upper age for everybody as being 80. So if you've got a grandparent in there that developed breast cancer at the age of 90, that won't be counted into the assessment. And then also when they're doing the calculations, there's in a way no point in putting a 90-year-old in there to try and work out their risk of developing a future cancer, because it will only give the risk assessment up to the age of 80. In a family where you've picked up 2 variants, so you might have picked up, say, a BRCA1 variant and a CHEK1 variant, the model is such that it will just go with the higher risk variant. So they'll deem the BRCA1 to be higher than the CHEK2 gene variant, and the model will therefore assume all the risks based on that BRCA1. And depending, they stratify the risk per gene. So BRCA1 being the highest risk of breast cancer, and RAD51D being the lowest risk. So whatever's before that they will base their risk assessments just on that one gene. So it's just bearing in mind that if you've got, say, a BRCA1 and a CHEK variant in the family, and your patient's tested negative for the BRCA1, in that assessment, they won't take into account the fact that she hasn't been tested for the CHEK2 variant. and therefore you might need to manipulate it a bit when you're using it. You might want to remove the BRCA1 when you're working out her CHEK2 risks, etc. So it's just to point out it's not perfect. If you've got 2 genes in there, it's only taking over the highest risk variant. When you're looking at those graphs that we showed, and it showed a population risk arm, if someone's had breast cancer, it also shows a population risk arm on those graphs, a population risk line for the risk of a contralateral or a breast cancer in the second breast. And that's just based on information in the general population. And it doesn't consider the treatment that she might have had for her breast cancer, any other family history information or lifestyle information. So just to say that that line of the graph also has its limitations. If somebody, like you're seeing a patient with ovarian cancer and you input their information, it will not give you their breast cancer risk. And that seems a bit counterintuitive, but it's just the fact that they haven't got enough data to base those ovarian cancer risks on. Sorry, those breast cancer risks on. And as I say, it does work out your risk of developing a contralateral breast cancer. So if we go back to our example, select on, say, her sister that's developed breast cancer, and we can make her the proband. Okay. That changes all of these tabs above. So it just puts in her sister as being the year of birth and the 1st of the 1st, but it doesn't have her height, her weight, etc. on it. So if you were using somebody else's pedigree and then tailoring it for another member of the family, you do need to go back through and enter those criteria. I'm not going to do that now because I just wanted to show you down here what that can do. So here's Chloe, who's now the proband, and I want to calculate her risk. Okay, so I want to look at her risk of getting a second breast cancer. Okay, we know she's already had one, so, and we don't know what surgery she's had on that side. So she might have had a breast cancer, she might have had a lumpectomy, and she might have a huge amount of remaining breast tissue on that side, but it will only calculate her risk of developing a breast cancer in the breast on the side that's unaffected by cancer. But it will give you this graph here, and it shows that her risk of a further breast cancer is still really high, up here sort of 88% between the age of 26 and 80. Okay. In the case of a BRCA1 variant, you think, oh yeah, I knew that risk was going to be really high, but it's still potentially useful for counselling if she's considering further mastectomy, and for people with the genetic changes in perhaps the more moderate risk genes that we think about, like the CHEKs and the ATM and things like that. It can be a really helpful estimation in trying to work out their future risks. So when they're working out the contralateral breast cancer risk, they calculate it using the age at the first breast cancer diagnosis and the genetic and other risk factors, including family history. But as I say, it doesn't exclude treatments such as hormonal therapies, tumour pathology, prognosis of the primary tumour, other competing risks. And it's, although we do use it for other genes, apart from BRCA1 and BRCA2, the data for those other genes is limited. As I say, it assumes that only one of the breasts remains at risk. So we use it, and we use it to look at the contralateral breast cancer risk, but it's just to warn you that it's not perfect. And I always talk to patients and say that this is very much an estimation. It doesn't take into the prognosis, your current cancer, etc., or the fact that you've now been taking tamoxifen for the last 5 years. So when we're using CanRisk, another potential pitfall that you can run into is that it excludes all breast cancers before the age of 20. So if you've got somebody, it's very, very rare to get a breast cancer before the age of 20, but if you've got a breast cancer in an 18-year-old and you've added that into CanRisk, beware that that will then it won't take that particularly into account when you're doing calculations. So if you've got a family history where a sister had breast cancer at 18, in a way you're better putting her in at 20 to ensure that she's still deemed in the calculation to be at relatively high risk. Okay. When we're putting in genetic changes, whether somebody has a variant or not in particular genes, it's assuming that they're a heterozygous carrier. And when I say heterozygous carrier, we have 2 copies of every gene in our body, and we're assuming that they just have a variant in one of those copies, and the other copy is just a regular copy. It's rare, relatively rare, that you get homozygous carriers, but for ATM, you get patients with ataxia telangiectasia that are at very high risk of breast cancer and qualify for MRI screening. They shouldn't be put into CanRisk as just a carrier of ATM variant. CHEP2 homozygotes, you can also get, so homozygous when both copies of the gene are affected. And obviously they will have a higher risk too. Any sort of patient like that, they would be under genetics if they were affected by ataxia telangiectasia. Obviously, if they've got 2 CHEP2 variants, they should be under genetics too. So we can advise on that. Sometimes BMI can affect the risk considerably, and sometimes it gives slightly counterintuitive answers to what you might expect with that. But basically, if you've got a high BMI, CanRisk software with the data that it's got basically has that as a protective effect up to the age of about 50, and then your breast cancer risk actually increases as a result of the high BMI over the age of 50.